How fast I talk. Got it.
Welcome to the June 6th, 2024 Talk with the Doc with Dr. Timothy Leichliter of Allegheny Health Network. Thank you as always, and we'll hand it off to you, Dr. Leichliter.
Thank you, Casey. Welcome, everybody. I am Dr. Leichliter. I am a so-called movement disorder specialist hanging out here in my office at Allegheny General. Soon to move office, by the way, but just to the other side of the hospital. I got my green tea here, so I'm ready to go. If you have questions, type them into the chat box. That's the best way for me to get to them. I'll start with the ones that I got emailed to me, but then I go to the ones in the chat box, so type away. As usual, a couple caveats that I always throw out here, which is this is kind of a general forum for patients, caregivers. It's not a great place to get one-on-one care. So maybe don't ask me, hey, I'm on this and this. What do you think I should do next? That sounds like a great question for your doctor and your team. And then the other thing I like to tell you is everything that I say is my opinion. I have a lot of opinions. I have no problems telling you my opinions. I generally think my opinions are based on the best medical advice or medical information I am aware of or can find, but sometimes I have to make stuff up because there is no good evidence. And so I make stuff up and I throw up quotation marks and I tell you I'm making stuff up. But it's my opinion. So if you go to another neurologist, you go to another movement disorder specialist, it may be their opinion, and their opinion may be different than my opinion. Probably not, but maybe. And so take that with a grain of salt. All right, with that, I will get started on email questions. And I know it doesn't look like I'm looking at the monitor, but I have two monitors, and so I'll be back and forth between my monitors. The end. You'll figure it out. All right. Can I share my thoughts about vitamin B1 therapy? So B1 therapy has been, discussed a lot. It's been talked about a lot, not just in my office, but in support groups through the foundation. And I get asked this question a lot, so this is not a surprise. I've probably answered it before, but it never hurts to hear the answer again. My jury is still out on B1, and I say that for a couple of reasons. So B1 is a vitamin, it's B vitamin. There's a lot of B vitamins. B1 is the one being talked about. There was a group out of Italy who was doing research on Parkinson's disease patients using higher doses of vitamin B1 than typical doses of vitamin B1, and they published a couple of reports, papers, I think even a book about the benefits that they had had. My concern for the reports and for the data was it all came out of one group who subsequently, unfortunately, the lead researcher, I believe, passed away of COVID. So I'm not sure what's going on out of their lab now. The problem that I have is that it has yet to really be reproduced. And so I like to see data that comes from multiple sources that all come to the same conclusion. So while it is good, I don't think it's quite, level one evidence that I can just start making actual recommendations for. When we're talking about a medication, they go through FDA trials, they get approved by the government and the branches that they kind of make those decisions, and they really require high class, high quality evidence. Supplements don't have that type of oversight, don't have that type of kind of big studies, randomized controlled things, and that's what makes it difficult to actually get a good recommendation. Now, I will tell you, unlike a lot of the other supplements, which I have no problems talking about as well, I've had some patients come back doing the B1 therapy and the protocols, and I would say for the most part they have had some success. I've heard good things. I've heard I have more energy. I've had more alert. My tremors are better. My walking is better. So I have heard good things about vitamin B1. So I'm not against you trying it if you want to. It's just you're not going to get a lot of the quality of evidence that I'm going to need to say, yes, across the board, everybody should do this, or this is a recommendation. What you're going to hear me say is I have had some patients have some success with it. I think there's some science backing it up and some rationale and some small studies to suggest it's beneficial. If you want to try it, knock yourself out. That's kind of my thoughts on B1. I don't think there's a lot of toxicity, though I have had a couple of patients who took it extremely high who did have some side effects to it, but nothing that didn't go away when they backed it back down. And so again, if you want to try vitamin therapy, you're more than welcome to. I don't have anything against it. It's just it's difficult to get a recommendation without the kind of typical or standard trials that we do for medications. Is low hemoglobin and hematocrit associated with Parkinson's disease? That's the first time I've been asked that. I'm not aware that it is. I'd have to look that one up, and there's no studies as far as I know that suggest it, but I'll look again. There is some correlation with iron deposition in the brain with Parkinson's disease and Parkinsonisms, and iron definitely correlates or plays a role in hemoglobin and hematocrit, but I don't know of any direct hemoglobin hematocrit association with Parkinson's disease. We read about a study done by Michael J. Fox linking B12 deficiency with neurological symptoms such as instability, numbness, and cognitive deficits. Have you observed this in your patients? If so, would taking vitamins correct this? So yes, you kind of nailed the symptoms of vitamin B12 deficiency, which are usually neuropathy, balance problems, cognitive problems. And yes, I would go out on a limb and say that in my experience, most people in Pittsburgh, and I would say most of my Parkinson's disease patients are low in B12. Now, B12 is a tough one because if you just look at the numbers, most labs suggest that low is less than like 200. But in neurology, we like people a little bit higher than that. And so I usually recommend people try to stay above 400. And yes, the short answer is if you take B12 to replace your B12 deficiency, it does correct the problems, usually, as long as there's not permanent damage. I don't know of any data to suggest that taking extra B12 or having your B12 be extremely high is all that beneficial. But I have had a lot of patients who are borderline or low vitamin B12, and so I'm not against taking it either. Again, vitamin B12 and D seem to be the two that are low the most commonly in my office. Maybe that's a Pittsburgh thing, I don't know. Maybe it's a Parkinson's thing, I don't know. Maybe it's just a my patients thing, I don't know. But I don't think you can go too wrong with taking a B12 or a vitamin D supplement, at least not around here. I've recently been experiencing hallucinations. Can I elaborate on the cause and possible solutions? Yes. So there's generally two different categories of hallucinations. So Parkinson's disease patients can have hallucinations, and hallucinations are a very prominent feature of diffuse Lewy body disease or Lewy body dementia. And these are really two very similar but different conditions, and they're treated relatively the same, but the expectations and the outcomes are fairly different. So Lewy body disease is one of the Parkinson's plus conditions. So it's Parkinson's-like, it can have similar Parkinson's symptoms, but it tends to progress quicker. They have prominent hallucinations, and they just don't respond as well to the medications. In Parkinson's, and there's a distinction in the hallucinations, and it really is what is the underlying cause. So in Parkinson's disease, we think it's more the medications that drive the hallucinations. So, every medicine that I use to help you move better can increase your risk of hallucinations. And generally, we think the higher the dose, the more likely the hallucinations are. And so the obvious first choice would be if you have Parkinson's disease and the hallucinations start, taking less medicine should theoretically help with the hallucinations. Now, taking less medicine also probably means you're stiffer, slower, and shakier because that's what the medicines do that are good. But at the end of the day, if the medicines can cause the hallucinations, and if you do decrease the medicine enough, the hallucinations should get better. The alternative is we do have medicines that we add to our patients to try to help combat the hallucinations. Generally, there's two, maybe three. So Nuplazid, which is pimavanserin, is the only FDA-approved medicine for Parkinson's disease psychosis. So it's the only actual FDA-indicated medicine for the hallucinations that come in Parkinson's disease. And you'll see us use a lot of that. The other two medicines are Seroquel, which has been used for 100 years. It's probably the most commonly used medicine for the hallucinations in Parkinson's disease, although it does not carry an FDA approval for that condition. And Clozaril, clozapine. Now that one's not used very much because we're limited by extensive blood work that has to be done fairly regularly and repeatedly. And so it has significant drawbacks to trying to use, but it's a great drug if you can use it correctly. But those are really the three medicines we would add to somebody if they are indeed having hallucinations and we can't get away with cutting back the medicines. Now, again, these are also the same medicines I would use in Lewy body disease for the hallucinations, but the difference is in Lewy body disease, the hallucinations are not driven by the medicines, they're driven by the Lewy body deposition. So you get these clusters of alpha-synuclein that deposit in certain areas of the brain, and that's what triggers the hallucinations. And so the underlying cause is different in the two different conditions, although the end result is hallucinations that are predominantly visual, usually people, animals, patterns, things like that. Can be auditory, but usually visual, and we end up treating them the same. So hopefully that answered your question. I've been experiencing increasing stiffness and gait issues, which have gotten worse over time. Besides exercise, could it be a lack of Cinemet? I mean, I don't know that I would say it's a lack of Cinemet. I would say it's a lack of dopamine. And Cinemet just happens to be the best way we try to replace dopamine. And so, yes, you could say it's a lack of enough medicine. And that's probably the easiest first choice, especially if the medicines really did work for you and you're noticing that over time they're becoming less and less effective, or you're having more symptoms, or they're wearing off. There's a lot of different solutions for this, and this actually will segue into I'm going to group together a couple of the other questions, which is really, can you go over the different medication choices for Parkinson's disease? One of the hardest parts about learning how to take care of people with Parkinson's disease, at least for medical students and residents, is there's about 6 or 7 different ways we can solve a problem at any given time. And depending on the specific scenario, the specific situation, I may pick different things. What we do for patients or how we treat patients is very individualized. And that's a hard thing to learn without spending a lot of time in my office seeing a lot of patients, which is what I did as a fellow. And that's why we have movement disorder fellowships. But the short answer to your question is, if you are noticing increasing problems, yes, you may need an increase in your medicine. I wouldn't look at it as a lack of Cinemet, but I would look at it as really your dopamine levels are down and we need to do something to try to bring them up. And then the next question, which really dovetails into the other question, actually one question that was added in late was, is there any comment on testosterone therapy in Parkinson's disease? And I haven't come across anything, at least recently, that I can remember off the top of my head, in terms of using testosterone in patients with Parkinson's disease, specifically for Parkinson's symptoms or things like that. If you're testosterone deficient, that will definitively make your Parkinson's symptoms worse. You will be much more tired and lethargic and slow and probably stiff and not feel very good. And so if you have a testosterone deficiency, you should have testosterone replacement. But I don't know if the question was specifically asking, is there any role for testosterone use in Parkinson's disease? And the short answer would be really only if you have a deficiency, as far as I know. I haven't seen any data or any use of testosterone for Parkinson's symptoms. And then the last questions that I got in email were really about the medications. And so let me take a minute to explain the different types of medicines, because one of the questions was, can I compare and contrast, the use of levodopa versus pramipexole? And then the other question was really just, can you talk about medicines for moderate movement challenges, benefits, side effects? Are there non-levodopa medications that might help? And, what's the advantage of amantadine, and so on and so forth. And so really it comes down to, can I go over the medications? And the short answer is yes, I can. So there are several different classes of medicines in Parkinson's disease. And so we'll take them kind of in order that I use them, or in order that I think about them right now. Since we think that Parkinson's disease is a loss of dopamine, or again, and this is questionable, don't get me wrong, but we think that it's potentially a loss of dopamine, and dopamine is a chemical that we think helps you move better, then replacing dopamine makes the most sense. Now, the problem with trying to just feed somebody dopamine is it doesn't get from the stomach to the brain. Your brain is actually a fairly protected organ. Your nervous system and your spine are fairly protected, in that there's a barrier between your blood and your brain. And not all medicines can get across this blood-brain barrier. And it turns out dopamine doesn't. So you cannot just feed somebody dopamine and expect it to get to the brain. They tried that, didn't work. But then another smart person came along and said, well, if we don't give dopamine, what if we give dihydroxyphenylalanine? That's always a bonus question that I ask my medical student or my residents, and they never get the answer right. So dihydroxyphenylalanine is what DOPA stands for. L-DOPA is just the L version of dihydroxyphenylalanine. So this has the step before dopamine in the conversion. You see a bunch of lines on my board. You can't see it, but I do have the dopamine pathway drawn up there. And sure enough, the line right before dopamine is dihydroxyphenylalanine, or DOPA. And it turns out it did work. They ended up feeding people L-DOPA, and it worked, but it had its own side effects. And then another smart person came along, well, what if we block the conversion of L-DOPA to dopamine in the stomach, so more of it gets to the brain? And that's how they invented carbidopa, levodopa, or Cinemet that we all know and love. So carbidopa, levodopa, or Cinemet is really still the gold standard medicine that I have in Parkinson's disease. There's about 6 different varieties of it now, from Cinemet to Cinemet CR to Ritari to Ambrosia to Duopa. Probably forgot a couple, Stalevo's in there. I probably forgot a couple more. There's about 6 or 7 different versions of levodopa that we can give you. But carbidopa, levodopa is still the gold standard medicine. It's as close as we can get to replacing dopamine. It's flooding your brain with levodopa that then gets converted into dopamine, and that restores the amount of dopamine you're supposed to have, sort of. But it comes with a price, and it has side effects. Every medicine we have has side effects. Probably the biggest side effect is still upset stomach. That's what happens when levodopa gets converted into dopamine in the stomach. That's why nausea is the #1 side effect, but it can cause hallucinations and dyskinesias, which are squirmy movements. It leads to a lot of ups and downs or fluctuations throughout the day. And so it comes with a price, and there's no doubt about it. And the short answer to one of the parts of the question is no, it is not the only medicine that we have. It's just the best medicine we have. It's the one that works the best. It's the one that affects symptoms the most. It's the one that impacts quality of life the most. And that's why, believe it or not, I was just cleaning out my desk, and I found somewhere here the Green Journal report where they suggested that pretty much across the board using Cinemet is the first choice in almost everybody. That was just in the past few years. And that's because it's the best drug that we have. It's the one that impacts quality of life the most. Yes, it has a price to pay and side effects, but it's still the best drug we have. The next class, or the next kind of set of medicines, would be the group of Pramipexole, ropinirole, and rotigotine. Also, apomorphine falls into this category, or this is Mirapex, Nupro, Requip, Apokyn. These are the dopamine agonists. So instead of replacing dopamine or supplementing dopamine, they just bypass the dopamine straight to the receptors. They activate the receptors, more along the lines of like a synthetic dopamine than replacement dopamine, natural dopamine. And these are probably the second most potent group of medicines that we have. And so if I have somebody where carbidopa, levodopa is not doing the trick, but I need something that still hits them pretty hard, Mirapex is probably my second choice. It's probably the second most potent drug that I have. If I have somebody who's have a lot of fluctuations, you'll see me use a Nupro patch because that's kind of steady state drug or medicine. If I have somebody who needs just a little bit of a boost, Requip's not a bad choice. If I have somebody who needs an as-needed medicine, so Apokyn is an injectable, it's a dopamine agonist. And so they have the same or similar side effects in that they can also cause hallucinations and dyskinesias. And for a while, we were actually using dopamine agonists before we would get to levodopa, thinking that if we held off giving you Cinemet, maybe we would prevent some of the side effects of it. Turns out that's not as effective as we thought, which is again why Cinemet's still the best first drug, but the dopamine agonists are a close second. They come with a couple of other kind of black box warnings or specific side effects that, not that you can't get them with Cinemet, but you see them more commonly with the dopamine agonists. One is impulse control problems. And so particularly in younger patients, particularly in men, it tends to make people impulsive. So we hear stories about gambling and sex and shopping and eating. These are, kind of big concern in using the dopamine agonists. The other is sleep attacks. So they can make you fall asleep at the drop of a hat. Now, the hard part is all of my patients are tired. That's the #1 complaint that I get in the office. So trying to figure out how much is the disease versus how much is the medicine is not easy. But these are all things we have to take into consideration where we're deciding what the next step is. The next class of drug is probably the monoamine oxidase inhibitor. So it turns out there's 2 different enzymes that break down dopamine in your brain. One is monoamine oxidase, the other is catecholomethyltransferase. So MAO inhibitors and COMT inhibitors block those enzymes and prevent the breakdown of dopamine, leaving more dopamine around in your brain. So the MAO inhibitors are Azalex, selegiline, safinamide. The COMT inhibitors are Comtan or Ongentys. And again, these are add-on medicines to usually levodopa to try to help them work a little bit better. Sometimes we use Azalex standalone, but not usually. Usually these are add-on medicines. And again, they're not usually as potent as Cinemet or potent as Mirapex, but they do give you a little bit of benefit. And again, because this is so much trial and error, we're trying to figure out what's the right medicine in the right spot for the right person. We try all these things. The last couple of, so one of the other kind of, I don't want to say class of medicine, it's just one medicine is amantadine. So amantadine is kind of a standalone drug on its own. It works actually on a bunch of different chemicals. We're not entirely sure how amantadine works actually. You'll see me use amantadine when I'm trying to help with walking imbalance. It works, in my opinion, it worked a little bit better for that than maybe some of the other medicines do. And it's the only medicine that we have that actually helps tremors, helps stiffness, but decreases dyskinesias. So there's 2 long-acting versions of amantadine. I don't know if Osmolex is still on the market, but Gocovri is, and Gocovri is the one medicine that's specifically FDA approved for the dyskinesias and Parkinson's disease. And so you'll see us use amantadine or the other versions of amantadine for that. Again, we don't really know how it does that, but it does. And so it does have some special qualities to it. It also can cause hallucinations. It can cause some sleep problems. It can cause some swelling. Mirapex also causes swelling. Amantadine can cause livedo reticularis, which is a red lacy discoloration to your skin. And so it also has some side effects. And the take home message is there's a lot of different drugs. They all have pluses and minuses, but none of them are free. They all come with a side effect profile. There is no such thing as a side effect free medicine. And probably the last class of medicine, although I'm probably forgetting some, which I try not to use very much, of the medicines that don't work on dopamine at all, but work on acetylcholine. So this is more benztropine and trihexyphenidyl or cogentin and artane. These are the medicines that were used back in the day before Sinemet was invented. They work really well at stiffness, maybe some tremors, but not so much at the other things. And they come with a hefty price tag of side effects of cognitive problems, brain fog, walking problems. So I try not to use them in my patients unless we have to, or unless there's a good reason. And that's kind of the order or the groups of medicines that we have. So there's definitely pluses and minuses to every medicine. And there's usually some specific tailored reason that we go to one drug versus another in you. So what we do in movement disorders or in neurology is fairly individualized or fairly kind of tailored treatment. You know, if you come in with a specific problem of wearing off, you may not get the exact same different medicine or treatment adjustment that the next person who comes in with it is. And there's probably a reason for that. Sometimes the reason is just what popped into my brain, but usually there's a better reason than that. And we're picking and choosing what we want to do depending on your other issues. Can I kill two birds with one stone? Is there a way that I can make this simpler and still try to get the best end result? That's a difficult kind of lecture to give. And again, it's really hard for medical students and residents and my APPs to learn these things because you really have to see a lot of patients. You have to spend a lot of time taking care of patients and just see it over and over to get a grasp on it. But that's kind of an overview in a nutshell of the different types of medicines that we use. Thank you, Elise. Apparently, it's my nurse. Osmolex is now off the market as of April. I didn't use it very much anyway, but I do have some that really liked it. So that's kind of it's always disappointing when a drug comes off market. Parcopa was the more recent one that really drove people crazy. So Parcopa was oral dissolving levodopa, which I think I forgot to mention in my litany of different Sinemets. And it was good for people who were nauseous with regular Sinemet. But again, and you can, I'll throw up quotation marks because I'm probably making this up, but I have a feeling I'm pretty accurate. It always comes down to money. I'm sure there was no money in it, and that's why they took it off the market. All right, now that was done with email. So now I'm going to the chat box. Balance problems. And balance problems are tough because balance problems are the most dangerous problem that I encounter. Because falling is the number one thing that lands my patients in the hospital, even more than infections or other things. Falling is what lands you in the hospital. And again, everybody has experiences, and everybody has a very similar experience of what happens when you end up in the hospital, and it's never good. And so our keys to success are really keeping you out of the hospital, which means we really have to keep you off the ground. Balance is tough because it's not one of those symptoms that's easily treatable with medications. It's also not easily treatable with things like deep brain stimulator surgery or other more aggressive things. The absolute best medicine for balance is physical therapy. Physical therapy, physical therapy, physical therapy, exercise, exercise, exercise. And yes, I know I talk a lot about exercise because it's my favorite topic, but it really is the only thing proven to actually improve walking and balance in ataxia or balance problems. Doesn't mean we don't try more medicine. I do, especially if you come in and you say, no, you know, my walking imbalance is significantly worse when my medicines wear off, or when this happens. And then we can try to adjust correctly. Balance is one of those things that I'll try to use more amantadine for. Again, amantadine is an all-purpose drug. We use it for a whole lot of things. And no, it's not great for balance, but maybe it's a little bit better than some of the other things. You'll also see me use dementia medicine, Alzheimer's disease drugs. So I'll use Exelon, which is rivastigmine. I'll use memantine, which is Namenda, sometimes Aricept, because it turns out that some of the cerebellar pathways, the cerebellum being the back part of your brain that helps control coordinated movement and balance, is driven by acetylcholine, not dopamine. Again, there's not a lot of data to support their use either, but there's some. Sometimes I'll use things like methylphenidate or Ritalin or other things that have very limited or very anecdotal evidence. But when we're talking about such an important or difficult problem as balance, I throw at you everything that I have or anything that has any data to support its use. We try it because it's that important of a problem that we really don't want to have you fall and end up in the hospital. And so those are probably the things that I would try or think about, when patients come to me. And so that's probably what I would aim. But again, coming back to the mainstay of training or treatment for balance is really physical therapy. Don't laugh or get mad when somebody says you have to go back to physical therapy. Somebody already answered this question for me, which was really how much B1 are they taking? And I would have said, I don't know anyway, because at the end of the day, there's a whole protocol about how high you go, how you increase, how many days a week you take it. And I actually never read the protocol, which is probably bad on my part, because people have been doing it. And I should probably look at it and learn a little bit more about it. But he answered it correctly. It does vary person by person. And I'm actually not up to date on the protocol or how much he should be taking. That's something you kind of have to go with whatever the protocol recommended. Interesting webinar coming up on Gene said no silver bullet for PD. Why am I optimistic that we might now have a silver bullet? I really hope we do have a silver bullet for PD, believe it or not. I haven't seen one yet, but that's a great question. And that actually reminds me that I have something written here on my desk that I was supposed to touch on, an answer from last month, which was a comment on the celestial light therapy trial. So I did look it up. They are doing light box therapy. And so basically this is a bright box that you sit in front of that shines a lot of light at you. And actually before this trial, I remember at the last movement disorder meeting that I went to in person, which I don't remember when it was because COVID throws off everything. There was actually a presenter on sleep problems and use of light therapy, and it was actually pretty impressive. They were suggesting that use of light box therapy significantly helps not only with the sleep problems, but the mood problems, energy problems. And there was different Luvox. Luvox is a drug. Locks, whatever they measure light in, there was different amounts that you can get, and they're really not that expensive if you look them up on Amazon. You can really get a good light box, kind of just buy it, over the counter or on Amazon for pretty cheap, if I remember correct. I haven't looked recently. And the presenter, and she was a sleep specialist from somewhere, and I can't remember her name or where she was from, but she gave a compelling argument or presentation on using light therapy for these things. And the same thing is what they're actually trying. So it's in a phase 3 trial now where they're using their own device. I'm not entirely sure what's different about it. Their website was not very clear exactly what their device was, but I think it's a light box and I don't know what their protocol is, but in phase 2 trials, they were having success with symptoms of Parkinson's disease. It's now in a phase 3 trial, so more to come. But there is known in some data out there that light therapy is good for people with Parkinson's disease, and it's usually used a light box early in the morning. It tends to help with energy, it tends to help with fatigue, it tends to help with mood, and it tends to help sleep problems as you go throughout the day. I can't say that I've necessarily given a prescription for light box therapy. I don't even know if that exists. I've talked to a few people about it. I should probably talk more about it with patients because I do think there's some data to support its use. And it's not another medicine, which would be beneficial. How do I know what my dopamine level is? How is that tested? Is it a blood test or what? It is not. The downside to dopamine is, as of now, we do not have a good, accurate test for dopamine. Yes, there are people out there that will draw your blood and test your dopamine levels. I have seen these reports. I have seen their information, and I just don't buy it. And I don't buy it for one really important reason, which is we don't have normal levels. We don't know what the baseline is. And here's why. Turns out dopamine is really hard to measure. You can measure it in blood, you can measure it in cerebral spinal fluid. But the amount of dopamine that you have or should have at any given time fluctuates dramatically. So the amount of dopamine you have is dependent on a lot of different things. It's dependent on how much dopamine you produce, which is really what we want to know in Parkinson's disease, is how much dopamine are you producing? Are you really, excuse me, not producing enough? But it's dependent on a lot of other things. It's dependent on your mood. It's dependent on what you ate. It's dependent on your sleep. It's dependent on your exercise and activity level. It's dependent on what you did that day. It's dependent on what you did the day before. It's dependent on your medicines. It's dependent on so many different things and so many variables that if I check your amount of dopamine that you have at any given time, I have no idea what that's a comparative to. I have no idea what that should be, because how much dopamine you should have sitting there relaxed watching TV is very, very different than how much dopamine you should have if you're out exercising, or if you're playing the lottery, or if you're hitting a slot machine, or a variety, or if you're eating. The levels of dopamine fluctuate so regularly throughout the day that it's really hard to know what normal is. And this is why I have yet to see an actual good test of dopamine. They've worked on it, they've tried, they've looked at it. It's a very difficult thing to pin down and target. And that's why there really isn't an accurate test for dopamine. We surrogately tell you you don't have enough dopamine because you present with the symptoms of somebody who doesn't have enough dopamine. And so what I always say is there's no test for Parkinson's disease. I am the test for Parkinson's disease. And so there really isn't a good test, at least as of today, to measure dopamine, to really give us the, believe me, I would love to have a test that tells me these things. My job would be infinitely easier if I could just send you for a blood test, a spinal tap, or an imaging study that gives me all the answers that I need. But that doesn't exist, at least not yet. So more to come on that. I'm hoping we come up with one, but today that does not exist. And so the test is really based on your symptoms and what you tell me. And then we treat it and we see if we can get you doing better. What would make me say that Cinemet isn't working, so we need to try something else? So one of a couple things would tell me it's not working. So one is you tell me it's not working, meaning it doesn't, you don't feel any different. You don't notice any benefit to it. It hasn't really helped or changed anything when we started it. Now, I do get a lot of patients who come to me already on it, or other medicines. And, their primary care doctor put them on medicine. They saw another neurologist before me and they put them on medicine. And then they say, well, I don't think the medicine's helping. And the best way to figure out if the medicine is helping is take it away. If I take away medicine and you're worse, well, then it was doing more than you thought, and we probably put you back on it. But the things that would make me think that Cinemet is carbidopa levodopa is not working very well is one, you tell me it's not working, or two, it was working, but now it's becoming less effective. I get a lot of people who come to my office who say, you know what, it used to last 6 hours and now it lasts 4. I used to go every 4 hours, but now I'm wearing off an hour before I'm due for my next dose and I'm feeling it. I used to not notice that my pills kicked in and wore off. I never felt if they were working. Now I do. So these are all things that don't necessarily tell me it isn't working, but are telling me that your disease is progressing or it's not as effective as it was before, and maybe we need to do something else. And so in those cases, that's when we have to figure out what to do. Do we need more of it? Do we need to move them closer together? Do I need to increase the dose? Do I need to add something else to it? These are all the individualized things that we could do to try to see if we can get you doing better. But those would be the indicators that maybe your Cinemet isn't working as well. And maybe we need to think of something different. If it's just not helping, if your symptoms are bothering you, then it's not working as well as we would like, and we need to be more aggressive or do something. Does Azilect help Cinemet work better? Well, sort of. So Azilect is a monoamine oxidase inhibitor. It's brain specific. So if you go back to the old fashioned antidepressant class of MAO inhibitors, they were non-specific, and those people needed to be on special diets. They couldn't take many other medicines. There was a lot of drug interactions. Because Azilect is an MAO monoamine oxidase inhibitor B, brain specific, you don't have to worry about those things. But it still prevents the breakdown of dopamine. And so yes, in that Cinemet replaces dopamine, carbidopa, levodopa, the levodopa gets converted into dopamine, and then the Azilect prevents that dopamine from being broken down, so it hangs around longer. And so yes, it does tend to help Cinemet work better or longer, and that's why we add it to other medicines to see if we can get kind of that synergistic or combination benefit, because sometimes two drugs really do work better in combination than either of the drugs individually. It's not uncommon for my patients to be on multiple different medicines. The philosophy in Parkinson's disease is a little bit different than the philosophy in internal medicine. If you have hypertension or high cholesterol, generally the thought is, okay, I'm going to put you on one medicine, and I'm going to ramp it up until I get you doing better, or until I hit a max dose, and then I'll add in something else. That is not exactly what we do in Parkinson's disease. In fact, I do the exact opposite of that. I would much rather layer in multiple different medicines to keep all of the dosages low, because oftentimes they do work better together, and multiple low dose medicines are better than any of those medicines ramped up to the highest dose, at least in terms of side effect profile, we think, or potential complications. And so the short answer is yes, I do add azelectinib as well as other medicines because the combination works better than just ramping up one medicine in general. Are the reasons that I would say there's no point to doing the new 3-prong skin test versus when you would want to do that? Yeah, there's definitely reasons. And so if it doesn't change my plan, that would be the reason I would say there's no point in doing it. Okay, so what is the skin test? So at the end of the day, there's 2 tests available for Parkinson's disease, 3 for Parkinsonism. Anyway, so a DAT scan. A DAT scan is a dopamine transporter scan. And this is a nuclear medicine scan that I can send people for to see if I'm in the right ballpark. It is not a specific test for Parkinson's disease, and you're going to hear me repeat this over and over again for everything. It at least lets me know I'm in the right ballpark. So it turns out if you don't have enough dopamine, or you're not creating enough dopamine, you don't have as much dopamine transporter. And so we can radio label that and it fluoresces, and whereas it should be nice, bright white and pink, it doesn't look so bright. And that tells us that we're in the right ballpark. You have a dopamine problem. What it doesn't do is it does not distinguish the difference between Parkinson's disease, Lewy body disease, multiple systems atrophy, some of the other Parkinson's-like conditions. The same thing is true for the skin test and the cerebrospinal fluid CSF test, the spinal tap test. Both of these tests can measure alpha-synuclein, misfolded alpha-synuclein, phosphorylated alpha-synuclein. Generally, alpha-synuclein being the protein that builds up in Parkinson's disease that forms Lewy bodies. You're going to hear a lot of talk about alpha-synuclein if you read about Parkinson's disease or new and kind of innovative ways to target it. But it misfolds, it leads to Lewy body formation, it gets phosphorylated, which means a phosphorus group gets added to it, and these are measurable. So you can do it in spinal fluid, you can do it in skin tests where we do 3 different skin biopsies and we look for this. You can find it in the skin. The problem is the same thing, which is, again, it tells me that I'm in the right ballpark. It tells me that you have an alpha-synucleinopathy, but it does not say this is specifically Parkinson's disease. It could be Lewy body disease. It could be multiple systems atrophy. It could be primary or pure autonomic failure. It could be one of these other conditions. And at least today, according to their websites, and I only know this because I just gave a talk on this not too long ago, their websites still tell you that they are not able to distinguish between the different types of Parkinsonisms. The skin test is working on it. So they're looking at different patterns, and potentially the pattern of deposition of alpha-synuclein can point you in one direction versus another, but I don't think it's quite there yet. And so if I need to know, am I in the right ballpark? You know, let's say I take care of somebody, I see somebody who has clear Parkinson's symptoms, but I put them on Sinemet and nothing happens. Or let's say somebody has a mixed Parkinson's type tremor, but also an action tremor, which is more of an essential tremor, and the medicines haven't helped. And now I'm thinking about sending them for surgery. You know, what you have, Parkinsonism versus essential tremor versus something else, dictates what we do. You know, if I have a Parkinson's patient who looks like Parkinson's disease, but I put them on medicine and nothing happens, is it because I'm wrong and they don't have Parkinsonism? This is a weird dystonia or Parkinson's plus condition, something completely different. Or is it because I just haven't given them enough? Some people don't respond until you ramp up the dose a little bit and give them a higher dose. And yes, I could just give them more medicine and find out, but that's where I like to do another test. If I do one of these ancillary tests and it comes back as positive, meaning they're in the Parkinson's realm, okay, then I feel more confident about giving them more dopamine medicine. If it's normal, well, then maybe I'm on the wrong path and I need to switch gears completely. So that's where I would use some of these tests. Let's say I have a patient who's got a mixed picture and I'm thinking about sending him for deep brain stimulator surgery. And then when we have a meeting, which I have tomorrow, we say, well, what target are we aiming for? That's when we really want to know the difference between, okay, is this really a Parkinson's type tremor or symptom and the subthalamic nucleus is a good choice? Or is this more of an essential tremor? Maybe I would aim for the thalamus. So again, it's kind of important to know where we want to put the wires when we're doing surgery. So again, when I'm trying to answer questions like that, tests are important. But just for the day-to-day person to figure out what they have, that's when I would say there's no good point to do the test, because it's not going to change any of my plan, at least not up front. In the typical patient, what we're going to do is what we're going to do, regardless of what those tests show anyway. And so again, that's how I view these ancillary tests. I'm hoping someday that we have better choices, right? I'm hoping we have a definitive biomarker. I'm hoping we have a marker of disease progression. I'm hoping we have an obvious test. I'm hoping we have a measure of dopamine. These would all really, really help me when it comes time to figure out how to treat somebody and how much medicine to give them. But until we get that, we're stuck with the tests we have. And those are kind of a little bit of insight into how I use them. What do I think about dopamine breaking down into adrenaline, keeping your body stuck in fight or flight and fear mode, thus not letting your body heal itself? So again, you can't see this here, but believe it or not, there is a dotted line from dopamine through catecholomethyltransferase down to norepinephrine and epinephrine. See, I have it right on the board here. So yes, I do agree with that. And it is true. We think about, dopamine problems, not just in Parkinson's disease, but in a whole lot of different things. And again, if you can't, if it does break down into these types of things and you have abnormal amounts of these different neurotransmitters, you do get different problems. And so that's not a bad thought. I mean, it could leave your body in this constant heightened awareness state, constant inflamed state, and not allow your body to naturally heal itself. There's no doubt about it. The hard part is I don't know what to do with that information. Again, I'm not sure how to correct that. I'm not sure how to use that to my advantage in terms of treating patients. It's a great thought, and it's probably partially accurate. I don't know that it's necessarily been proven or pinpointed exactly. I know different researchers have had different thoughts on dopamine levels, dopamine being toxic, dopamine being the problem, so on and so forth. The guy in Cincinnati whose name I'm blanking on right now is the one that comes to mind up front. But at the end of the day, I don't know how to use that to our advantage. I just had a conversation with somebody about the brain-gut interface, which we know all about, but I just haven't figured out how to use it to my advantage. I think all of these are interesting ideas, and they're great potential research trials or great potential ways to try to target Parkinson's disease in new and novel ways. I just haven't figured it out yet. And I'm waiting for other people to figure it out, because there's much smarter people out there than me, to kind of give me an idea of how we can hack into these things, or how we can use these things to our advantage to, again, try to help people not only feel better, which is what we try to do now, but potentially intervene, delay disease progression, or potentially cure. I mean, I think it's a great idea. I think it's quite possible. I just don't know what to do with that or how to use that to our advantage. I'm glad you pointed out that we know the importance of exercise. Would I please explain again how while in the short term it requires more dopamine, it is beneficial in the long term? Sure, sort of. I hear a lot of times in my office that when I exercise, after I'm done exercising, I feel worse. I'm shakier, I'm stiffer, I'm slower, particularly if you overdo it, which I often say don't do. But again, in my simplified brain state, it does make sense that if you're exercising, if you're putting in a lot of work, you're going to burn through dopamine more quickly. And thus you're going to run out faster and you're going to have more symptoms. And so, yes, I do think there is some short-term, more higher requirement of dopamine when you're exercising or when you're active or when you're doing things. But I also think the long-term benefits of exercise outweigh that risk. Now, the hard part is I cannot explain to you how the long-term benefits come. Is it that your brain is then conditioned to produce more dopamine, or it does so more efficiently or effectively? Is it that the receptors reset or adjust, and maybe you can use your dopamine more effectively? Is it more mitochondria? So again, mitochondria being the powerhouse parts of the cells, which we know are affected in Parkinson's disease, or the advent of Parkinson's disease. It seemingly helps them function better, smoother, longer, faster. Is it really just that when you exercise, you help your cellular functions clean up cellular debris or break down products of all the reactions that happen in your body and in your cells? Coming back to how alpha-synuclein tends to clump when it's not functioning correctly or when it gets phosphorylated. Maybe it helps your cells kind of clear that debris out better so that you're not having deposits of these things. The short answer is everything that I just said is completely myth. And we really don't know. Is it just that musculoskeletally, it helps your heart, your muscles, your posture, mechanically you do better? All of these are philosophies or thoughts about how exercise could potentially work, could potentially be disease modifying or slow down your disease. It's just that none of it's proven. And that's the hard part about all of these things. Finding actual evidence is tough. Um, I can't say that we've cracked the code of how the human body works or the brain or the nervous system works. And so it could be any one of those, it could be none of those as to how we think exercise actually helps people do better in the long run. The short answer is all I can tell you, and I won't say that exercise is proven to be disease modifying because it isn't. All I can tell you is that in my experience, the people that exercise the most are the ones that do the best. Every single person who has ever rotated with me, every medical student I have ever had, every resident that I've ever had, every APP that I've ever had, whoever has rotated with me can vouch for seeing this in my office time and time again. The people that come in and say, I've been dealing with this for years and still look great. I don't even have to ask how active they are. They automatically throw out that I've been running 5 days a week my whole life. I've been going to the gym forever. I do marathons. I do whatever. Every single time, the patients who come in that are doing the best are the ones that exercise the most. And again, I can't prove that. All I can tell you is that has been my experience. And that's all I can say for definitive. My opinion. Yes, I have an opinion. And I was just reading the story. So had a partial hip replacement due to fall. Was given a spinal rather than general anesthesia since fracture was not extensive. The doctor thought this was better for people with Parkinson's. However, they did mention that surgery can affect Parkinson's. Only in hospital overnight, my opinion. So yes, yes, and yes. So when I was a fellow, now going on 10 years ago, I did a chart review study that I never published, looking and comparing spinal anesthesia or local anesthesia to general anesthesia. And I found there was a significant difference. So the people who got general anesthesia, after their general anesthesia and surgery, they did require more medicine. They had more symptoms. Now, a lot of times it was temporary. And it was something like 50% of people with general anesthesia and 30% of people with non-general anesthesia got worse. So again, the numbers weren't tremendously different, but they were different. Now, the argument to myself from myself on my study was that it is in no way or shape or form comparing apples to apples. People who require general anesthesia are often having a much more extensive and difficult surgery than people who can get away with spinal anesthesia or local anesthesia. So that study, while interesting and gives me some information to tell you guys, probably not the best study in the world, which is why I never published it. But at the end of the day, there was a difference. And the difference was that people who underwent general anesthesia did tend to worsen or have more symptoms or require more medicine more frequently than people who had other types of anesthesia. Is that proven? No. But we do know that anesthesia is not good for the brain. Your brain was not meant to be artificially put to sleep and woke up. It's not good for it. It's been shown in Alzheimer's disease and Parkinson's disease that it can make these symptoms worse. And so my opinion is that anything we can do to avoid general anesthesia is probably better for your brain. So if they can get away with a spinal anesthetic, it's probably better for people with Parkinson's disease. I can't say that for sure. That's just my own opinion. Take it for what it's worth. Again, if you need surgery, you need surgery, right? If they're going to fix your hip, they're not just going to give you a shot of whiskey and a stick to bite on. You're going to get some sort of anesthesia, the end. I get a lot of questions about surgery. Should I have this surgery? Is this surgery a good idea? And my general answer is usually the same. Look, if you have a problem, particularly if you have a problem that's keeping you from doing the things that we want you and like you to be doing, i.e. exercise most of the time, then it needs to be fixed, period. If you were missing out on the absolute best medicine for you, again, exercise, because of your hip or your knee or your back or your neck or whatever, then fixing it, yes, it comes with a risk, but if it allows you to get up and do the thing that we think helps you do the best, the longest, it's worth it. That's kind of my general rule. I have no problem picking up the pieces and trying to figure out how to adjust medicines if you are indeed worse after surgery, if the end result and the main goal is better function or better mobility or better outcome. That's how I always view it. And so, yes, I think that's interesting. I agree with your doctor. I think a spinal was a better choice if that's a possibility. But I also don't tell people they can't have general anesthesia or surgery, particularly if the outcome or the end result is getting you back to doing the things I want you to do to begin with. Do I know of any data or benefit on hypnosis and Parkinson's? Data, no. Anecdotal, yes. I had a patient, man, I feel like it must have been a long time since I've seen him, who insisted that hypnosis helped him for Parkinson's. He actually went somewhere. I'm blanking on all the information because I feel like it's been a really long time since I saw this person. But at the end of the day, he went somewhere who was well known in the hypnosis world. I won't even say Canada, but I might be making that part up. And he really felt like it helped. He felt like it helped his mood. He felt like it helped his movement and mobility. But I don't know of any actual studies on this stuff. And I can't think of anybody else who's ever come back and said, hey, I did hypnosis for my Parkinson's disease and it worked. Now I can logically extrapolate, and I'm going to throw logically extrapolate in quotation marks because I don't know if this is actual logical. But if hypnosis does anything from a mood standpoint, if it can calm you down, if it can relax anxiety, if it can take care of depression or things that I think that they look at hypnosis for, then secondarily it should help your Parkinson's because all of those things amplify Parkinson's symptoms. And so maybe secondarily, I can make a logical jump that hypnosis or things like that could help Parkinson's, but I don't know of any data to support that. Have I heard of the X39 patches and reflect your own red light back into your body to repair your mitochondria? I feel like I did look that up one time, but it's been a while, so I can't say that I know a lot about it. But I have read more about red light therapy, and my guess is this is kind of based on the same underlying science and idea, if that's what it's aimed at doing. Again, red light therapy has been looked at in Parkinson's disease. It's still being looked at. Again, the data is okay. I mean, there is some data to suggest it helps people feel better, but the data is iffy in my opinion. But again, it's not one of those things you're going to do randomized controlled trials and get gold standard care. I'll look up the patch. I'll let you know what I think, but my guess is it's probably, if you want to try it, you're more than welcome to. I haven't heard anything toxic or damaging about red light therapy. I haven't had too many people do it, but at the end of the day, I haven't heard of too many side effects or problems with it. And there's some science in how it affects mitochondria, lysosomes, and repair of these cellular things. And so maybe there's something to it. I don't know how expensive it is. And so my general rule of thought is don't put yourself in the poorhouse doing stuff like this. It's not as proven. But my general thought also is if you want to try it, I'm not against it. Let me make a note here. Pen. Give me 1 second. So X39 patches. I'll look it up for you. Let you know what I think, and I'll give you my opinion next time. Or the time after next time, since next time doesn't exist. So is the treatment the same for those different Parkinsonisms, just finding the right combination of medicines? Yes and no. So what I mean by we use the same medicines is I have a handful of medicines for Parkinsonism. Anybody who comes in with tremors and stiffness and slowness of movement and balance problems, i.e. the definition of Parkinsonism, it's really the same medicines. The downside is if you have a Parkinsonism or a Parkinson's plus condition, they're just not as effective. I still use carbidopa-levodopa. I still use pramipexole. I still use Nupro. I still use Retari. I still use Azilect. I still use all the same medicines, but they're not as good. They're not as effective. And so the short answer is yes, the treatment options are the same. And yes, we do still try to find different combinations. It's just that I'm not entirely sure what the end result is going to be or how effective it's going to be. Probiotics and Parkinson's. So again, talking about that gut and the brain connection, which we know of, and we know that the gut bacteria in people with Parkinson's disease is significantly different than the gut bacteria in quote unquote normal people. I don't know any normal people, but supposedly there are some. And so could probiotics, prebiotics, could changing that gut bacteria help? Maybe. I mean, logically, it makes sense. Scientifically, it makes sense. I just haven't seen it. There's a couple of trials in a fancy number probiotic that I was blank on, but and it's touted for people with Parkinson's disease. And I've actually had some patients try it and they do feel like it has helped. But again, the evidence is tough. It's hard to do good trials on these things. The gut bacteria are very complicated. The gut nervous system is very complicated. So trying to do clear And really, black and white studies is really difficult, even if you find somebody who would pay for it. And so that's a tough one. I have a lot of patients that take these things, and some of them say it helps, some of them say it doesn't. Generally, same rule of thumb, which is, there's some science there to back up the use of gut changing things. And as long as you're not putting yourself in the poorhouse, I don't think the risk is very large. I can't think of many people who've come back and told me about bad side effects. So, go for it. Can cinnamon help with swallowing difficulties? That's a tough one. Sometimes yes, sometimes no. If your swallowing dysfunction is a muscle problem and it's a stiffness, maybe. If your swallowing problem is mechanical or something completely different, maybe not. Some of my patients swallow better when their pills kicked in, and when their pills wear off, they don't talk or swallow as well. But that's one of those things that I'm not sure. It's iffy. Swallowing is definitely not one of the things I say, yes, cinnamon is a great choice for. It's going to fix this. Swallowing problems is one of those things where I say, well, maybe let's try this and see what happens, but I'm not entirely convinced I know what's going to happen. And so the short answer is it can, but not always. And it's definitely not one of the slam dunk symptoms. Right? I hate this story, but I hear this story all the time. Yes, it's a Medicare game you have to play forever. So to recap, is this a typical problem for the elderly? So balance and falling is the problem, and exercise is the key. But when you fall, physical therapy doesn't want to work with you. And if you ever end up, and this is a big problem that I end up, and I'm going to actually end after this question because this is going to be an interesting story. So one of the big problems I run into isn't necessarily with outpatient physical therapy, although if you're a fall risk, they're not going to want to work with you. And then, so how do you get better and well enough so that they'll work with you without them working with you, which is this fun catch-22 that never really works. But where I actually, and so they actually got him into a rehab and he improved, but then insurance doesn't like to cover inpatient rehab. It's actually extremely difficult to get somebody into an actual inpatient rehab from home without a hospital stay in between. And so insurance dictates everything. Yes, it's a game you have to play with Medicare, getting coverage for therapy or inpatient stays, so on and so forth. But where I actually run into this problem the most is it's some sort of skilled living facility. So a skilled nursing home or skilled nursing facility, an assisted living facility. I actually just had a patient where we run into this today. We know that walking, getting up, moving is absolutely the best and most important medicine for you. But it comes with a risk of falling, right? And so if you're in any type of assisted living or skilled facility, what's the easiest way to make sure you don't fall? Not let you get up, right? You become a fall risk. You get a yellow band or something that alerts people that, hey, you're not allowed to be up walking on your own. And then sure, they say you have to call us and we'll help you get up and walk and we'll take you for walks, but nowhere has enough people to actually help people. And so what happens? They end up not walking, they end up sitting in a wheelchair, they end up staying in bed, and they get worse. And the problem that I run into all the time is a difference of kind of most important thing. So when you come to my office with Parkinson's disease, my most important thing is your quality of life. So the best quality of life we can get you is the number one topic in my mind. That's my number one goal. That's my number one priority. When you end up at the mercy of somebody else, meaning you end up in a skilled nursing facility or an assisted living facility or somewhere where somebody else gets to make the decisions, their number one priority is no longer your overall best quality of life, it's your safety. Because everybody gets dinged for something, right? No matter where you go, what job you're in, what field you're in, you get dinged for something. Well, guess what? At a nursing home or a skilled facility or an assisted living facility, they get dinged for you falling and they get dinged for you ending up in the hospital. And the best way to make sure you don't fall and don't end up in the hospital is to not let you get up. And so it's a difference of philosophy, right? It's a difference of priority. Now, they always outrank me. Every 10 times out of 10, whoever's in charge of the living facility, the skilled nursing facility, is going to outrank my philosophy, which is that you need to be up moving as much as possible, even if that is at the risk of extra falls. And so this is a problem that I run into not only in this situation where, again, a outpatient physical therapy feels like you're too dangerous to work with, and maybe they won't work with you, and then we have to get you stronger somehow so that we can get you into therapy. But it's definitely a problem that I run into in anybody who comes from any type of living facility. Because again, it's a difference of priority. And again, a lot of these people, physical therapists, and I'm not bashing physical therapists. I'm not even bashing skilled living facilities or assisted living facilities. Believe me, they have their pluses and minuses, but their priorities are almost always going to be safety, safety, safety over everything else. And again, that's where the tough part is we simultaneously have to get you doing better so you can then be safe enough to participate in physical therapy or be allowed to get up and walk on your own. But how do we do that without getting the therapy and the exercise needed to make that happen? And so this is a problem that I run into a lot. This is a very difficult situation that I have not solved or figured out a solution for by any means. But yes, I would say this is a typical problem for the elderly, not just with the insurance coverage of these things, but also with the priority of whoever's actually making the decisions. And it's something that we just have to figure out how to work around. And with that, I am almost on time. And so I will pass it back to Casey to wrap us up.
Thank you, Dr. Leichliter. Thank you everyone for attending. And since next month's talk is on the 4th of July, we'll be meeting in August. August 1st is our next talk with the doc.
I look forward to it. I will be there.
And save the date for our Step Forward fundraiser, Saturday, September 28th. It's at the Shrine Center Picnic Pavilion in Cheswick. We've been there the past few years. We'll see you on August 1st. Thanks everyone.
Guys. Have a good one.
Bye.